Vidal, it's good to see you again. Thanks for joining us today. I appreciate you taking some time. Thought it would be interesting to go through the strategic priorities and the survey insights that you recently did going into 2024. Kind of what's persistent, what's changed, what's emerging. I think we'll just dive in. I've put a few questions together and let's see where this conversation takes us. I'm kind of excited to hear from you.
Me
One
too.
of the things in your survey that you mentioned around these six priorities was that strategists are really focusing on their growth and sustainability in 2024. And I know that a large part of that is really focused on the benefits of technology investments and how they can help out in hospitals sort of from this post-pandemic recovery. How are you seeing that play out so far since we're over three-quarters of the way through the year?
I think one of the issues that still remains persistent, even if health systems find themselves in a better position financially, is trying to generate greater productivity and staffing stability, as that's still somewhat inconsistent nationally. And that's a really smart place where you could imagine the deployment of technology either to ease workflow, to offset certain tasks, to shift where tasks are delivered, or to do them asynchronously. And while I think there is still a large uphill climb for most health systems and their teams to deploy technologies in such ways, we are seeing advancements, particularly on the non clinical side for pattern recognition, for interaction with patients through chatbots, and also for clinical documentation. So I think we are seeing some green shoots of using technologies in different ways, particularly as it applies to our workforce and our productivity of those teams.
Yeah, I know you and I had talked before, and you mentioned kind of a diversification around non-clinical versus clinical domain spending. And, it's a little bit less intrusive. Obviously, it doesn't have quite the impact on the non-clinical side as it relates to degradation or potential impact for clinical management. But, we're facing some really challenging times, right? I think in your survey, you mentioned 40% of respondents are experiencing margins below 2022 levels, right?
Right.
So, hospital size, I think, comes into play. I think I recall looking at some of the data, the larger health systems seem to be a little bit insulated from that. But for hospitals that don't have capital to invest in technology and in particular CapEx, how are these strategists looking to technology to sort of stretch their capital budgets? You have any insight around that?
Yeah, so I think there's two things that are emerging. One on the partnership side, so co-development with technology companies or technology leaders to identify smart places where you can apply emerging applications so that workflows are optimized or are improved as opposed to overlaying the technology on workflows that are suboptimal. So in that situation, what the health system gets is transfer of expertise and support on change management in return for the ability to use some of these technologies to offset some of these persistent workforce challenges. The other part really much more connects to the money, which is to say, can we go into a outcomes based contract or value based arrangement whereby we can guarantee certain outcomes or pull forward some of that expected return to be able to fund the necessary investment that is going to be required to input and make the change and leverage the technologies in smart ways. So either kind of exchange of expertise from technology leaders to the health systems workforce, or pull forward of some of the spend or the revenue that would be expected to be unlocked from doing this work in collaboration with technologies.
Yeah, I can speak to what we're seeing. If you think about gain share versus pain share, there's still a general reluctance, right, from a
Yeah.
contracting standpoint to enter into that. But what there does seem to be more of an appetite in embracing is to have the OEM partners, if you will, bring in their expertise to address what you mentioned around optimizing workflows. Using the technology that you have, but really making sure that you're incrementing and optimizing the use of that and tweaking it accordingly to be able to support the various needs and challenges that they're experiencing. Along those lines, are you seeing any vendors in trying to respond with CapEx constraints looking to alternative, finance models, maybe moving to solutions as a service type of a model in supporting that CapEx expenditure?
So it's a great question, and not one that I've seen kind of dedicated or consistent outcomes. Obviously, the bigger players are extending some of this technology platform to health systems as opportunities to offset what would have been an expenditure they would have to have occurred alone. One Medical being one example where a lot of that technology and referral pattern analysis is being extended to their selective partners. Now, it is very hard to replicate the size and breadth of Amazon, even if their entry into healthcare is somewhat inconsistent. So I think it's largely, at least as what we've seen so far, been in the domain of very, very large institutions that have deep pockets as well as willingness to invest in the necessary platforms and the technologies to offset. But that I don't think that necessarily means that that's the way it's going to go forward. The secret sauce in being able to enter into any of these value-based or gain share, pain sharing arrangements is the level at which you are confident that you could return the outcomes that you're guaranteeing, and in doing so then be able to bring the change management and work along, and perhaps even pull forward some of those expected returns to be able to offset the immediate costs that we would incur.
That's insightful. Thanks for sharing that. One of the other survey main insights was this idea of going back to basics, really focusing on increasing quality, workforce and operational efficiency. Um, and so, you think about trying to leverage what you have today because of CapEx constraints. And you mentioned your confidence in being able to prove out outcomes. Are you seeing a lot of ties to a return on investment model, whereby some of these partnerships are exploring that as a way to drive a business framework?
Yes, and I think that partly influences why we're seeing, at least on the health system side, more activity and appetite for applying technologies in the non-clinical space versus the clinical space. Partly because either you could very clearly measure from a cost perspective what the reduction was by automating or offloading activities to a technology. Additionally, if you're thinking about revenue cycle or revenue capture, which is another kind of ripe area for application of technology and automation, that's another place where you can clearly measure how much more kind of yield you've been able to unlock from having an automated function that collects payment from payers. And so that I think is partly why there's more appetite there. The harder, perhaps also ripe opportunities of the application of clinical technology, both in the to support productivity and clinical decision support. The challenge there is bringing people along, particularly clinicians, to trust and understand the technology and what it's doing, and still allowing them for clinicians to feel like they have autonomy and control over decisions, and that these technologies are supportive, not supplanting their importance in the overall decision making tree for healthcare.
Yeah. Yeah, we've talked about that before in a couple of other podcasts where, I think the AMA advisory board there, they identified augmented intelligence as opposed to artificial intelligence to try to change the
Yeah.
mindset, and the adaptation around that, or the adoption of it, I guess I should say. Let's talk a little bit about care variation reduction, because I think, and again, you've differentiated between the clinical and the non-clinical side. I really think that that's a big area where operational efficiencies can drive this. But can you speak to, first of all, really what is care variation reduction as a definition, and then how do you see technologies and strategies being implemented in support of that?
So at its core, care variation reduction is about ensuring a consistent series of activities towards an outcome for which all players or parts of the ecosystem are doing what they're expected for the patient or for the outcome that we're projecting. And the challenge there, well, that would sound like that should be baseline for healthcare and what we do every day. Clinical decisions and clinical training are very much oriented towards individual independent thought and synthesis of information. And while everyone starts out kind of learning what best practices when they first enter into clinician work or medicine, over time they develop their own heuristics, which means three doctors in three different sites might be delivering three different modalities of care for the same type of condition. And so, what care variation says is that can we collectively agree on a set of standards, activities, and approaches for patients presenting with certain conditions, such that regardless of whether or not the patient went to site A, B, or C, we could guarantee that they would receive the level of care that we would want them to. Um, this, as you would imagine, in some ways, looking at it externally, care variation or series of activities are algorithmic in nature, right? And so you could imagine an overlay of technology being supportive, ever present, synthesizing information, helping to identify gaps, which I think is where we want to go. The challenge is that bringing people along with that portion of trust and augmented intelligence as opposed to artificial intelligence are all part and parcel of the change management work that we all have to accomplish over time. And I would say that this is still the holy grail of operating efficiency within healthcare, precisely because of the way that we educate clinicians, but also because if you would imagine a world where increasingly health systems or all types of providers are going to have to be able to be transparent about what they cost, how much they deliver, and the outcomes that they're committing to payers, the market, or the consumer, increasingly these types of standards are going to be necessary in order to guarantee you're delivering what you're promising to the market or your community.
Hmm. I want to, and this is one that just kind of makes me think, is there a connection? So I'm going to ask you if you would agree or not agree with this. But one of the findings in the survey was around volume versus margin.
Yeah.
And, I think when elective procedures were pushed off during COVID, the thought and hope was that by bringing those volumes back, we would necessarily see a proportionate improvement in margin. But we know the patients are more complex. We know throughput has become, a significant challenge. And so when you talk about care variation reduction, could that be, you mentioned as the holy grail, could that in part at least be a part of helping to drive throughput? And then the second question to that is, what are health systems doing, since volumes are not bringing back the margins that they had intended? What are they doing differently to offset that?
So, absolutely, care variation reduction in that work is critical to offsetting some of the structural factors why volume might be up, but margins are not increasing at the same level. And that is partly because the cost of labor is now higher, the cost of supplies are higher, and healthcare and medical costs have always exceeded inflation even before this period of time. And so, as you would imagine, kind of appropriate use of supplies, appropriate site of care delivery, appropriate handoffs and decisions, all which fall under the wider umbrella of care variation reduction, are going to be critical and would be critical in having a better shot of improving margin. Um, I would also say that this is another place where we are finding it can be a critical lever for offsetting another structural challenge that many health systems are finding themselves in, which is an increasing number of junior or novice clinicians who are seeing a patient population who are increasingly more complex, either because they're complex at the point that they showed up or they've delayed care because of the pandemic, but also they might be more inclined to be publicly insured as opposed to commercially insured. So the margin you're working with to begin with is going to be lower. And as these junior clinicians step in, they're going to want to have a better sense of what is expected, what should happen next, and what are the expected handoffs that should occur as this patient moves through the system. And you could see care variation standards or care variation reduction as being the way you elevate the performance of junior staff very quickly. And so I definitely agree with your point that this is one of the solutions to offset the problem around volume margin decoupling.
Yeah, there's been a lot about knowledge complexity gaps of late, right? And
Yep.
speaking with that junior workforce. So I think that's a really good tie back. So we've only got a couple minutes left. What do you advise for health systems going forward to kind of manage this evolving landscape? If there's, two or three nuggets that we can give as takeaways, what would you say?
It's a bit of a well-worn hat, so I'm a little cautious to say it, but every challenge offers itself an opportunity or a path to make sizable changes. And as we are thinking about persistent workforce shortages and our more junior staff coming in, this experience complexity gap, this is a ripe opportunity for us to do what we've always hoped to do, which is to use technology in a way that is additive of productivity as opposed to a drag in productivity. And so, what we are required to do that or to make that unlock is to think differently and unpack and repack workflows as opposed to simply overlaying technology and expecting it to, by definition or by application, improve that workflow. So, again, it's going to be a lot more about auditing where are the gaps, where are the handoffs, where are the white spaces that we want to change and improve, and then think about technology as ways in which we can guarantee or smoothen those transition points, so that we are not having patients fall through the gap or we're not delaying decisions that are necessary for the patient. Then I think the other question is just how are we in a world where we leverage data in a way that is different than we have in the past? We've often thought about data as a rich source of information for us to make clinical decisions, but have been woefully kind of under leveraged to this point. As we're in a moment where kind of artificial intelligence has now become part and parcel of our lexicon or augmented intelligence, how are we thinking about the synthesis and analysis of the reams of information that health systems have in order to predict and adjust our workflow appropriately as opposed to being reactive, which is what I would characterize health systems behaving right now?
Can't recall if it was you or one of your colleagues that recently interviewed Karen DeSalvo from Health Information Officer around the amount of data that exists
Yeah,
in healthcare and how much of it is unstructured. So lots of good challenges that provide opportunity for us. Well, it's been a real pleasure, as always, seeing you again. Thank you for all of your wisdom and insights. Very much appreciate you coming together on this Ask the Experts interview with us and look forward to talking and working with you more.
absolute pleasure. Thank you.
All right, take care. Thank you.